Welcome to the Deep Dive. Today, we're jumping straight into the world of IVF, specifically trying to make sense of all those different treatment protocols. Our mission is really to demystify them, explain what they are, and maybe more importantly, why your doctor picks one specific recipe just for you.
Yeah, that personalization is absolutely crucial. Anyone starting this journey, quickly finds out there's no single standard treatment. Your whole protocol, the medications, the doses, the timing, it's all engineered based on your specific situation. Things like, well, your age, your ovarian reserve
Break
markers.
AMH and antral follicle count, right?
Exactly, your AMH, your AFC, and also your medical history. Maybe you have PCOS, maybe endometriosis, all that factors in.
Okay, so the doctor's really acting like a custom tailor here, not just
Yep.
checking a box. Let's break down the main strategies they use. Maybe we start with the two big ones you hear about, the long protocol versus the short protocol.
Sounds good. The main difference really comes down to how they control ovulation, preventing it from happening too early. Nature wants to release that egg, but we need to control the timing for the retrieval. So let's start with the agonist protocol, often called the long protocol. Its key feature is something called downregulation first.
Down regulation.
Yeah.
Sounds like putting the brakes on.
Pretty much, yeah. We use specific medications, GnRH agonists like Lupron are common, to temporarily shut down your natural hormone production completely. Think of it like hitting a reset button. It creates a clean slate. So when we start the actual stimulation drugs, the gonadotropins, all the follicles hopefully grow together, really synchronize.
That sounds super precise. But if you're stopping the natural hormones first, that must add quite a bit of time to the whole process.
It absolutely does. It's definitely the longest route. You could be looking at maybe 3, even 4 weeks just for that suppression phase before the actual 8 to 14 days of ovarian stimulation even kicks off. Historically, it was often used for women with a really good ovarian reserve where that precise synchronization was the main goal. But yeah, that suppression phase, it often brings on temporary menopausal-like symptoms, hot flashes, headaches.
Right, which sounds like a tough way to start an already stressful journey.
It can be, yeah. Which leads us to the alternative.
The faster way, the antagonist or short protocol.
Exactly. The antagonist or short protocol has really become, I'd say, the more common choice in many clinics these days. And yes, it's faster, primarily because we skip that whole long downregulation part. Stimulation begins much sooner, usually around day 2 or 3 of your cycle.
Okay, but if you start stimulating right away, how do you stop the body from just, ovulating naturally too early? What stops that LH surge?
Good question. That's where the GnRH antagonists come in drugs like cetrotide or orgalutrin. But we introduce them later in the game, usually several days into the stimulation phase. Their job is just to block the pituitary gland from releasing that LH surge signal. So it keeps the eggs maturing safely in the follicles until we're ready for retrieval.
Ah, okay, so it's more like a targeted block later on, rather than a total shutdown at the start. What are the big advantages of going shorter, besides just the time?
Well, the time saving is significant. Obviously, you're looking at maybe 10 to 12 days from starting stims to retrieval, which feels much more manageable for many. But clinically, a huge advantage is safety, especially regarding OHSS, ovarian hyperstimulation syndrome. Because the antagonist protocol doesn't suppress the pituitary so early, it lets us use a different, often safer, trigger shot to mature the eggs.
Okay, a safer trigger shot. That sounds important. How does that work? Why is it safer?
So the standard trigger shot uses HCG. The issue is HCG lingers in your system for quite a while, sometimes weeks, and it can keep stimulating the ovaries even after retrieval, increasing the risk of severe OHSS. But with the antagonist protocol, we can often use what's called a GnRH agonist trigger instead. This uses your body's own pituitary hormones. It causes a surge, but it dissipates much, much faster. This really cuts down on that prolonged ovarian stimulation after retrieval, significantly lowering the risk of severe OHSS. That's a major reason why the short protocol is often preferred now, especially for, say, older patients, those with diminished ovarian reserve, or anyone with PCOS who are already at a higher OHSS risk.
Wow, okay. That level of control and focus on safety is really something. So we've got the long and the short routes covered, but we know fertility isn't one size fits all. What about patients who maybe don't respond well to those standard high doses medication or who want a gentler approach?
Right, that's where we move into protocols like mild IVF, mini IVF, and even natural cycle IVF. These are designed for patients who might be low responders or perhaps are sensitive to high hormone doses or simply want to minimize medication exposure.
Fewer injections, potentially fewer side effects? That sounds appealing. But I guess the trade-off, if you're using lower doses, or just the body's single egg in a natural cycle,
Hmm.
is fewer eggs retrieved.
That's generally the trade-off, yes. You're aiming for fewer eggs, so the success rate per cycle might be lower compared to a conventional protocol that aims for, 10, 15, or more eggs. It's a shift in focus, maybe quality over quantity. For some people, this gentler approach is the right fit, maybe for financial reasons, personal beliefs, or just because they can't tolerate the high doses physically. It's about adapting the treatment to the person.
Okay, that makes sense. So we've talked gentle. Now, what if the challenge is the opposite? The patient is maybe a known poor responder, and the goal is to get as many eggs as possible, really maximize the yield.
Then we start looking at more intensive or customized strategies. Sometimes we use combined protocols. These might blend elements of both the agonist and antagonist approaches. For example, maybe start with some downregulation, like the long protocol for control, but then bring in an antagonist later. These are often used for tricky cases, like unpredictable responders or people who haven't had success with standard protocols before.
And then there's the one that sounds really intensive. Duostim or double stimulation. What's that about?
Yeah, Duostim is pretty much the most intensive approach. It's designed to maximize egg collection in the shortest possible time. It actually involves doing 2 rounds of stimulation and 2 egg retrievals within a single menstrual cycle. You do the first one in the usual follicular phase, then start stimulating again soon after for a second retrieval in the luteal phase of the same cycle.
2 retrievals in 1 month. Wow. Who typically needs that kind of approach?
It's mainly for 2 groups. First, patients who are identified as severe poor ovarian responders, where every single egg counts. Second, patients needing urgent fertility preservation, like before starting cancer therapy, where time is incredibly critical. Duostim basically doubles your chance to collect eggs in a very compressed time frame.
That's incredible dedication to maximizing potential.
Yeah.
Okay, let's shift gears slightly to another big strategic decision we see more and more, the freeze-all approach. Separating retrieval from the actual transfer.
Absolutely. Freeze-all, or elective cryopreservation, as it's sometimes called, has become really common. It means after the eggs are retrieved and fertilized, all the viable embryos are frozen using a super-fast freezing technique called vitrification. Vitrification is key. It prevents ice crystals from forming, which used to be a big problem with older freezing methods. So the embryos survive the freeze-thaw process really well. The transfer, the FET, or frozen embryo transfer, happens later in a separate cycle.
So why the delay? If you have good embryos ready to go, why wait weeks or even months to transfer them? What are the main medical reasons for doing a freeze-all and then an FET?
There are really 3 main evidence-based reasons. Number 1 is safety, specifically reducing OHSS risk. We talked about how stimulation can increase that risk. If a patient looks like they're heading towards OHSS, delaying the transfer is crucial. Getting pregnant adds hormones that can make OHSS much worse, even dangerous. So freezing all is a vital safety step in those cases.
Okay, so let the ovaries recover completely before asking the uterus to do its job. Makes sense.
Exactly. The second reason is optimizing endometrial receptivity. Sometimes the really high hormone levels during stimulation, especially high estrogen from lots of growing follicles, can make the uterine lining, the endometrium, less receptive to an embryo implanting. It might be sort of out of sync. Freezing the embryos allows those hormone levels to return to normal. Then, in a later FET cycle, you can prepare the lining under more controlled, natural, or gently medicated conditions to be perfectly receptive. We usually aim for a lining thickness of about 7 to 14 millimeters.
So creating the ideal welcome mat for the embryo rather than transferring into a potentially stressed environment right after stimulation.
Precisely. Optimize the environment for implantation. And the third major reason is pre-implantation genetic testing, or PGT. If you're testing the embryos for chromosomal abnormalities, you need to biopsy them, send the samples off, and wait for the results. That takes time, usually a week or more. So freezing the embryos is necessary while you wait for that crucial genetic information to help select the healthiest embryo for transfer.
Got it.
Yeah.
So whether it's for safety, better uterine conditions, or genetic testing, the freeze-all approach gives you that time and control.
It really does. And thanks to how good vitrification is now, the survival rates for frozen embryos are excellent, usually well over 95%. The success rates for FET cycles are generally as good as, and sometimes even slightly better than, fresh transfers, likely because we've eliminated those potential negative effects of high stimulation hormones on the uterus.
This whole conversation just hammers home that central point, doesn't it? That every single decision in IVF, long versus short, mild versus duo-steam, fresh versus frozen, it's all based on incredibly personalized factors and a careful weighing of risks and benefits for that specific person.
That really is the core idea. The goal isn't just maximal stimulation, it's optimal stimulation for that individual. And these protocols aren't set in stone. If a cycle doesn't go as well as hoped, it's a learning process. The doctor looks at what happened, why, and adjusts the recipe for the next attempt. Maybe changing meds, doses, timing, or even switching to a completely different type of protocol based on what they learned. It's a dynamic process.
Which means that precision in following the protocol is absolutely critical for the patient too, right? Missing an antagonist shot or getting the trigger shot timing wrong, that could really impact the outcome.
Oh, absolutely. It's a finely tuned hormonal dance, and sticking to the schedule, especially for things like the antagonist injections and that final trigger shot, is incredibly important for the cycle's success.
Well, this has been incredibly informative. Now, just before we finish, we absolutely must include our standard reminder. This discussion has been purely for educational and informational purposes. It should never, ever be taken as a substitute for professional medical advice. You should always consult with your own doctor for personalized diagnosis and treatment plans.
That's right. And if you're looking for more comprehensive information on the entire in vitro fertilization process, a great resource to check out is ivfforme.com.
IVFforme.com. Thank you so much for that insight today, and we'll see you all on the next deep dive.